Hi, yeah. So my name is Matt Stevens, and I work in the flow cytometry lab at the Royal Hallamshire Hospital. And this presentation is about a rare and interesting case that we had come through our laboratory. So it was a patient who had a previously diagnosed follicular lymphoma, which subsequently progressed to B-lymphoblastic leukemia. So on the flow cytometry for this patient, it was possible to identify two malignant cell populations. And as such, we wanted to compare the results between two of the analyzers that we have access to. So one being the BD FACSCanto 2, and then the other being the Sysmex XF1600. So firstly, just a little bit of context about flow cytometry at the Hallamshire Hospital. So the majority of our flow cytometry work feeds into the hemato-oncology diagnostic service, which covers several hospitals within the South Yorkshire region. And that clinical service is performed on a BD platform. So we have one of the older FACSCanto 2 analyzers and then two of the newer BD Fax Lyrics. Then in addition to that, we're also a reference laboratory for Sysmex Europe flow cytometry. So we provide evaluation, validation, and research work for Sysmex on their XF100, 1600 flow cytometer, their PS10 prep station, and then their cell wash centrifuge. Sorry, my screen's just having a problem. I don't know how to get rid of that. Okay, so back to the case study. So this patient originally presented in 2014 with a persistent lymphadenopathy. And if we look at the full blood count results from the patient at this time, you can see that they had entirely normal peripheral blood parameters, apart from extremely mild monocytosis. However, histological examination did confirm that the patient had a diagnosis of follicular lymphoma. So follicular lymphoma is known to be an indolent disease, and as there was no peripheral blood or bone marrow involvement at the time of diagnosis, the patient was put on a watch and wait protocol and didn't receive any treatment. And then fast forward to 2020, the patient represented with a lymph node mass to the right groin. And then again, we performed a full blood count. We found that they had a low hemoglobin and then an abnormal white cell differential plot on our Sysmex XN10 analyzer. So what you'd expect to see in a normal patient is a separate lymphocyte population and then a separate monocyte population. But you can see for this patient, those two populations are merging together. So when you see that, that either generally indicates the presence of blast cells, atypical lymphocytes, or plasma cells. So we had a look at the peripheral blood morphology, and we did find that the patient had blast cells and then some small lymphocytes with high NC ratio and cleaved nuclei. So progression of follicular lymphoma to more serious diseases is a known phenomenon, but that would be usually to diseases such as diffuse large B-cell lymphoma or Hodgkin's lymphoma. So progression can also happen to B-lymphoblastic leukemia, but this is extremely rare. So one of our consultants, Dr. Nick Morley, he said he's only seen 3 of these cases in the 20 plus years he's worked at our trust. So it is extremely rare. So based on what we saw on the peripheral blood, the patient was sent for a full bone marrow workup. And we've got an example of the morphology here. So on the left, we've got examples of blast cells. So on the peripheral blood, there's a blast cell, but the morphology is better on the bone marrow. So we can see the cytoplasm is heavily vacuolated and they're strongly basophilic as well. So that can be an occasional finding in B-lymphoblastic leukemia. And then on the right, we've got a couple of examples of small lymphocytes with a high NC ratio and then a cleaved nuclei, which is quite typical of the previously diagnosed follicular lymphoma. So when we performed a differential on this patient's bone marrow, we found that approximately 80% of the cells were these blast cells. So we needed to do some immunophenotyping. So we performed our in-house acute leukemia panel, which we use for all patients who've got a case of suspected acute leukemia. So we originally performed that on our BD FACSCanto 2 analyzer, just as part of the clinical service for this patient. Then, as I said, you can identify 2 malignant cell populations within this case. So we also wanted to test that on our Sysmex XF1600 to show that the analyzers were comparable with regards to antibody expression pattern and staining intensity. So for the next plots, we're going to have the Sysmex plots on the left and then the BD plots on the right. And you'll see as we're going through, the plots are virtually identical and would result in the same immunophenotype and therefore same diagnosis at the end. So the first plot, we've got side scatter versus CD45, and you can see they've got this large population of cells with low side scatter and weaker CD45 expression when compared to our lymphocyte population. So generally, when you're seeing cells there, that indicates the presence of blast cells, which fits in with the morphology that we've seen. So we've gated around those so that we can get an immunophenotype for them. And then additionally, because it looks like we can see some of that previously diagnosed follicular lymphoma, we've also gated around the mature lymphocytes to see if we could pick those out as well. So then we've got CD10 versus CD20. So a common characteristic feature of both follicular lymphoma and B-lymphoblastic leukemia is that the malignant cells often express CD10. And when we compare that with CD20, in this case, it does give us a really good separation between the two malignant cell populations. So starting off with the blasts, we've got really bright expression of CD10 and then they're negative for CD20. So bright expression of CD10 is really common in B-lymphoblastic leukemia, and 20 expression is variable. So we're in keeping with that suspected diagnosis. And then with the suspected follicular lymphoma cells, we see that that 10 expression is weaker than our blast cells, and they're also positive for CD20. So that is in keeping with follicular lymphoma. So something to be careful of with follicular lymphoma, this patient hasn't had any treatment, but if they had done, it could have been rituximab, which targets the CD20 antigen. So you may experience a loss of that CD20 antigen. And then the green events we've got on here are coming from that lymphocyte gate we created. So the dual negative events are most likely going to be T cells and natural killer cells. And you can see that there's also a small population of normal B cells, which are expressing CD20, but negative for CD10. Okay, so the next plot shows a very similar thing. So we've got CD10 versus the B lineage marker, CD19. We see that both our malignant cell populations are expressing CD19. And then it gives you a better indication of that relative CD10 expression. So really bright in our blast cells, and then our follicular lymphoma cells are slightly weaker. And then again, we can also see that small population of cells which are CD19 positive and negative for 10, which are going to be normal B cells. And then we've got CD20 versus CD19, again showing a very similar thing. I just left this in to show the importance of using multiple antibodies to pick out your malignant cell population and to also look for the abnormal phenotype. So just looking at that, it looks like you've got good separation between your follicular lymphoma cells and your blast cells, but cells that are expressing CD20 and CD19, your normal B cells also express that. So within there, you've also got your normal B cells. We've already shown on our previous plot that there is still a population of normal B cells. So it's the CD10 antigen which shows the abnormality in those follicular lymphoma cells. Okay, so for the next couple of slides, we're just going to focus mainly on the immunophenotype of the blast cells. So although we have demonstrated that we can pick out those follicular lymphoma cells, clinically for this patient, the most important thing is that it looks like they've transformed to B-lymphoblastic leukemia. So we need to make sure we're getting the proper immunophenotype for those blasts. So we've got CD34. Our blaster expression HLA-DR, but they're negative for CD34. So DR expression is really common in B-lymphoblastic leukemia, and CD34 expression is variable. So we're still in keeping with that suspected immunophenotype. Okay. And then the last plot we've got is testing for the cytoplasmic antibody expression. So we've got CD3 versus TDT. So we use the BD Intrashore kit to make sure the cell membrane is permeable to the antibodies. So we're therefore testing for the cytoplasmic antigen expression. So we can see our blast cells are negative for cytoplasmic CD3. And I should say at this point that our acute panel covers various other myeloid T and B cell markers, but I've only shown the positive antigens in this case. So we have excluded the other phenotypes. And then blasts are positive for TDT. So they're primitive primitive lymphoid marker, which is most often but not exclusively expressed in acute lymphoblastic leukemias. So a diagnosis of B-lymphoblastic leukemia should never be made off of flow cytometry alone. So all of our results feed back into the hemato-oncology diagnostic service, and then we make a consensus diagnosis based on the results from us in flow cytometry, histology, genetics, and then bone marrow aspirate morphology. So starting with our results, we've got 82% lymphoid blasts expression in DR, CD10, 19, and TDT. So morphology and immunophenotype in keeping with precursor B-lymphoblastic leukemia. And then additionally, we've put a comment about the mature B cells that are expressed in CD10 and CD19 and queried whether this is low-level involvement of the known for follicular lymphoma. Then we've got the histology results, and they've agreed with us and said transformation of known follicular lymphoma to B-lymphoblastic leukemia. So interestingly, in that one, there's no mention of this residual lymphoma. So that shows the analytical sensitivity you get from flow cytometry when compared with a morphological technique. And then genetics, they detected a BCL2 rearrangement, which is consistent with follicular lymphoma. And then our aspirate morphology, we've got heavy infiltration of lymphoid blasts. So our consensus diagnosis was disease progression of the known follicular lymphoma to B-lymphoblastic leukemia. So a few conclusions from this one. So progression of follicular lymphoma to B-lymphoblastic leukemia is rare with a poor prognosis. And in this case, we found that both the BD FACSCanto 2 and the Sysmex XF1600 were comparable with regards to antigen expression pattern and staining intensities. We do feel it's important when assessing a new analyzer to try and include these complex cases with multiple malignant cell populations, just to make sure that you have that analytical sensitivity. So thanks for listening. If you have any questions, you can ask them now, or you could send us a question to this email address or these email addresses. Thank you.
Thank you, Matt. That was fantastic. So guys, if you do want to ask a question, if you scroll over your screen and down the bottom, you'll see a chat function. You can ask any questions by using that chat function. So just whilst we're doing that, Matt, I do have a question for you, if that's okay. Yep. So you can tell that there is a definite difference between the XF1600 and the Canto plots. So can you give us a little bit of information as to why you see that difference, please?
Okay, just let me share my screen again. That's not letting me scroll through now. I don't know why I can't scroll through them. It's hard to say without the plots being able to see them, but there were slight differences throughout there, but it's mainly due to the scaling that we've used. But that's all adjustable on the XF and both the Canto, so you can adjust that as you would. And from the use I've had with the XF, it's very easy to do that, even with me being used to using the BD analyzers as well. Yeah, so all adjustable.
Cool. And can you give us a little bit of information about what you found experience-wise with the XF1600, so from a usability point of view?
So we've got the Sysmex analyzers in main lab. So if you've got any experience of using them, then everything's going to be pretty self-explanatory for you. But it's also quite easy to use. You can just go in and have a look around and you can find what you need to do. So like me coming from a BD background as well, I found it quite easy to do the same things that I can do with the BD on the XF as well. So yeah, quite good.
Lovely, thank you. Well, it doesn't look as though there's any questions, and it looks like our time is just about up anyway. So I just want to thank Matt once more for doing this for us and doing the presentation. If anybody does have any questions, then please, you can ask us on the booth and we will be able to get in touch with you. So thank you very much for joining, and go to our booth and enjoy the rest of ESCCA. Thank you. Bye-bye.
Thank you.